I have a bunch of stuff.
Calculation, do you want us to print it out and like print it in, or is it like something we can?
It's easier if I can write on it,
Okay,
so I prefer print it out, yeah.
okay.
She did 2 different patterns.
So Audrey, is there any news on your dad?
Yeah, so he's developed ARDS. And the doctor told us today that he also has, I'm probably gonna say this wrong, Haemophilus influenza.
Haemophilus influenzae?
Yeah.
So he has pneumonia on top of that.
He has, yeah, pneumonia from COVID.
And then
But
he
his-
has upper respiratory infection of Haemophilus,
Yeah.
excuse me. Okay, so,
Yeah. But his ABGs are normal and they hadn't been the past couple days, so
okay, so he's holding his own.
yeah, he's fighting.
Okay. All right, well, we'll keep pulling for you.
All right, well, thank you.
Did you guys all hear that? Yeah, so. Our pop's got a double infection, but he's pretty stable. He's not getting worse, so there is a silver lining. Okay, let's go ahead and jump right in. We're going to talk about GI drugs. Did you guys all bring your handout with you that I sent to you? Because we're going to make copious use of that handout. Let's have a word of prayer, then we'll begin. Father, thank you for today. It's sunny, it's very cold, and we pray for our athletes who are out in the cold, playing soccer, playing baseball, playing softball, probably freezing their toenails off. Lord, watch over them. And we think of Maddie, who's playing right now, help her to stay warm. Thank you for this time together. Please help us make a good use of it and learn about the treatment of GI problems. In Jesus' name, amen. Okay. GI drugs. Let's talk about different types of GI conditions and the drugs that are used to treat them. So for the first one, let's go ahead and talk about gastroesophageal reflux disease. And then those drugs will also be used to treat peptic ulcer disease. Peptic ulcer disease. So if we start with gastric esophageal reflux disease, with this disease, so you have the lower esophageal sphincter right here, and then the pyloric sphincter would be there. I should put that in a different color. So this is defective, and therefore you get stomach acid that goes up into the esophagus. The stomach is well designed to handle acid. What sorts of anatomical modifications does the stomach have to handle acid? Can you give me a few of them, maybe, some of you? What about the lining? That's correct. So the lining is lined with lots of mucus. And that mucus is impregnated with bicarbonate. So not only can it resist the acid that gets near to the epithelium tends to protect itself with things that will neutralize acid. Also, the stomach has a rich blood supply and a very high mitotic index. Not so for the esophagus. The esophagus, relative to the stomach, is relatively thin. When the acid leaches into the esophagus, it gets burned by the acid. You get ulcerations. Those will then heal. They get wounded. They heal again. They get wounded. They heal again. This is a prime site for the development now of cells that divide uncontrollably. So this can lead to this condition known as Barrett's esophagus. This is a precancerous condition. It's potentially very dangerous. Esophageal cancers, when they arise, are very aggressive. So you just want to keep them from arising in general. Before you get esophageal cancer, you might get esophagitis, you might get strictures, hemorrhage, and things like that. So gastric esophageal reflux disease is no fun, to be sure. So the classic signs and symptoms will include, let's go signs and symptoms, will include things like heartburn, you might also have regurgitation, might also have kind of a acid taste in the mouth. Those are your more typical symptoms. Some people just get a chronic cough. Others get a sore throat. And some people just mysteriously lose their voice. Others may have non-cardiac chest pain. So this, even though these are your typical symptoms, there are non-typical presentations as well. So don't fall into a one-size-fits-all kind of view of GERD. All right, so how does one diagnose GERD? Usually with endoscopy. So you're going to do a gastroesophageal duodenoscopy, a GED. That's usually the way you do it. You just take a scope, you go down, you look at this, you look at the stomach, and you look to see if it's normal or not. Okay, what about peptic ulcer disease? Peptic ulcer disease used to be thought peptic ulcer disease was due to stress, worry, things like nursing school, stuff like that, final exams, midterm exams, pharmacology for nurses classes, things like that, tended to cause you to overproduce acid. That's no longer the case. Now, if you do have peptic ulcer disease, stress can definitely make it worse. It doesn't seem to be the cause of peptic ulcer disease. So what does seem to be the cause is Helicobacter pylori. We talked about this last time. This is the main cause of peptic ulcer disease. This organism lives in the stomach, makes a very powerful urease. It surrounds itself, therefore, with ammonium. That neutralizes the acid. The organism has several ways to attach to the stomach mucosa, and it can cause gastritis and then, bless you, peptic ulcer disease. So these can bleed. You get a GI bleed. And then they can be perforated. Now, one set of drugs we'll see that can lead to ulcers are NSAIDs. Those are your non-steroidal anti-inflammatory drugs. That would include aspirin, ibuprofen, naproxen sodium, salsalate, meloxicam, piroxicam, your mother-in-law cam, essentially all those that are used for pain and inflammation. That's a downside of the NSAIDs. They can lead to peptic ulcer disease. Okay, remember that a gastric ulcer is often made worse with eating. A duodenal ulcer tends to be relieved by eating. Peptic ulcer is made worse by eating. A duodenal ulcer tends to be relieved by eating. Except for that difference, the symptomatology is roughly the same. You have heartburn, you have belching, bloated feeling, nausea, anorexia, so on and so forth. And that's also diagnosed by endoscopy. All right. So with Helicobacter pylori, you usually use the triple treatments. We talked about those last semester, but I will just very quickly refresh your memory. You're usually going to use a proton pump inhibitor, and then you're going to use two types of antibiotics, usually. Typically, one of those will be metronidazole. The other will be either Augmentin or maybe a fluoroquinolone or something like that. And that very effectively treats the Helicobacter pylori. You cure the Helicobacter pylori, the ulcer goes away. Either, it depends essentially what the organism is sensitive to. You can use Augmentin with metronidazole, or you could use levofloxacin with Augmentin or levofloxacin with metronidazole. Or you could use, for hard to treat cases, you could use Augmentin, levofloxacin, and metronidazole. That's called quadruple treatment. And then you usually use also a proton pump inhibitor. Okay, let's get into the drugs used for GERD and for peptic ulcer disease. Oh dear, that bled through. So first, over the counter, you have the antacids. So the strategy here is really very simple. You have a stomach that's full of hydrochloric acid. You're going to use things that will neutralize that acid. What things neutralize acids? bases. Now, does that mean you're going to drink lye? Gosh, no. I actually saw that on the web. Okay. That person needs to be reported and that needs to be taken off the web. That's dangerous. Instead, you're going to use weak bases, things like bicarbonate or things like carbonate. These will tend to neutralize the acid. So for example, Tums consists of calcium carbonate. Tum, you know, that's going to neutralize acid. Now, the problem with that is you may need to keep popping it on a regular basis. And now your calcium levels are going to get pretty high, and that may not be so bad for you. So once in a while, this might not be a bad idea, but if you're taking a lot of this, probably a bad idea because of the calcium buildup. Then you have other things like magnesium hydroxide, that is milk of magnesia. MOM, milk of magnesium. It will help with that too, yes. Tends to draw water from the bowel into the GI tract and tends to loosen things up, shall we say. Then there is aluminum hydroxide. That is also known as Malox. Now this one, if you take this one often, overdosing on aluminum is really not a good idea. So if you're using this one often, that's not good either. So if your patient takes stuff like this, make sure you ask him or her, how often do you take it? How much do you take? And for how long you've been taking it? That's going to be an important question. So these are all products that you're familiar with. If you add to aluminum hydroxide, this stuff called simethicone. Simethicone is an anti-flatulent. So this plus aluminum hydroxide, that is called Mylanta. Now, some of these things, if you have had bowel surgery tends to shut your bowel down. You tend to be pretty plugged up after bowel surgery. In fact, if you've had a hernia repaired, and I should know because I've had two of them, one when I was a baby that I don't remember, one that I do remember when I was in my 30s. These sorts of things can be very useful because after surgery, your bowel shuts down. You just have to wait until your bowel just kind of recovers before you can rejoin the human race, as my brother puts it. So Mylanta essentially will prevent flatulence because that tends to deal with gas bubbles with this. So there are lots of products. These are over the counter. When used occasionally, they're not a problem. They neutralize acid and they can raise intragastric pH. That's how they work. Neutralize acid, raise gastric pH. So when we use our mnemonic use, what are they for? They're for peptic ulcer disease or heartburn or something like that. And the name, we've talked about the names and what have you. Okay. So what's your responsibility? You have to ask the right questions. How much? How often? And if they're using this stuff a lot, something is wrong. They use it occasionally, not an issue. They go to Taco Time Bomb and they have the Tijuana special and they pop a couple of Tums. Oh, that was last week, not a problem. But they're taking it every day. Now that's a problem. Okay, let's talk about side effects. Some of these can cause constipation. Some of these, on the other hand, like milk of magnesia, can cause diarrhea. They can also cause pH disturbances. So if you cause acid-base disturbances, that can have other problems. So those are your side effects. Okay, here's your education purpose. If your patient has renal impairment, then you want to avoid things with aluminum and magnesium. The kidney will have trouble if it's impaired getting rid of those. If these build up in your system, that's going to throw things out of whack. So with renal impairment, these should be avoided. Next thing you want to educate your patient about, these can prevent the absorption of other drugs. They can prevent absorption of other drugs. Next, if you have an erosion in the stomach or duodenum, these will not heal it. Not for healing. These are for symptom release only. They tend to require frequent dosing, but they do act rapidly. So very rapid acting. So Mr. Berkmeyer comes in and he says, I've got this awful heartburn. I went to my in-laws and, you know, my sister-in-law Janice made her awful meatloaf. And just, boy, ever since then, it's awful. And he pulls out his Tums. You're going to ask him? How many of those you took in? Now, if he's taken one, then big deal. If he's taken 7 or 8, now that's a big deal. Now that might be a concern. Okay. Any questions about antacids?
At what point is it considered heartburn versus GERD? Like, is there a certain like a red flag or something?
Heartburn is usually if you eat something, then you have the heartburn.
So like, when should a red flag go? When he's like,
So some people have sensitive stomachs. They just certain foods set them off, and it's intermittent. It goes away, and it's not a big deal. Sometimes those types of things can be mitigated by drinking more with their meal. Or some people, if they have alcohol with their meal, the alcohol will actually irritate their stomach, especially if it's combined with certain foods. So again, history. That's one of your big jobs. Did you have alcohol with your meal? No, I'm not judging you. Just, did you have any with your meal? Do you notice if you have alcohol that you You have a little something, it hurts your stomach. Maybe try drinking less with your meal. Do you have wine before the meal? That might irritate, maybe try having the wine with the meal. Therefore, there's something to buffer the alcohol. Because some people, alcohol really irritates their stomach. Other people, used to teach her, Ruben Rubio. Ruben, pork products, just drives his stomach kablooey. And if he has anything, any bacon, ham, anything like that, it's just, some food sets some people off. And what do you do in that case then? You still help them find a way to systematically, through elimination, figure out what that is. So that's heartburn. It's predictable and it's intermittent. GERD or PUD is going to be constant. And GERD gets worse when you lie down at night, whereas heartburn will tend to go away. Also, this is the other thing, Sydney, this is pretty important. Heartburn, if you change your diet, tends to get better. GERD, if you change your diet, it's not going to get better. All right, now, there are also products with antacids plus alginic acid. What on earth is alginic acid? Alginic acid is actually, maybe fish. Do you know those little fishing lures, plastic fishing lures that's used, they imitate worms? Alginic acid is a catalyst used to make those. Alginic acid is a gel-like substance, and it's very, very heavily hydrated, and it tends to coat your stomach and tends to decrease the pain from heartburn or peptic ulcer or something like that. So this is for short-term relief. The name of this product is, don't tell me. Gaviscon. So you get this viscous barrier that floats on the surface of the gastric contents, and it acts as a barrier to reflux. So it serves as a barrier. And then the antacids are going to neutralize the acid. All right, so it's for relief of heartburn. I'm just going to say HB, relief of heartburn. Let's go to side effects first. This may tend in some people to cause nausea because this will tend to suck water from the GI tract. This will tend to thicken the bowel contents and cause constipation. And in other people, it can tend to cause diarrhea. Okay, so your responsibility in this case is to essentially educate the patient. This stuff is pretty safe. The only issue is that and acids in it, it's calcium, so it's not magnesium or aluminum, something you need to be really all that afraid of. But with this, your responsibility is to educate. And the education is, it doesn't heal, not for healing. It is not a potent neutralizing agent. And it does not, oh, goodness, can't see that at all. It does not enhance lower esophageal sphincter function at all. So this is just for temporary relief of symptoms. That's all it's for. This will also require frequent dosing. This will also prevent the absorption of other drugs, but it does act quickly. Gaviscon, also over the counter, serves as a barrier, relief of heartburn, that's what it's for. All right, now, other over-the-counter drugs include the H2 receptor antagonists. So, to refresh a little bit of stomach physiology, you have in the gastric mucosa, you have the parietal cells that make the acid. Those are signaled by the G cells. G cells make, remember what they make? They're called G for a reason. Gastrin. Gastrin. Natalie, you're looking at me like I'm from Mars. You heard of gastrin? No? Well, you just heard about it now. So gastrin is a endocrine hormone. It's a small peptide. It's released into the bloodstream and then it signals to the parietal cell to make hydrochloric acid. Then you have another cell. This is called an ECL cell. ECL cell releases histamine. And histamine signals to the G cell to make gastrin. And the receptor on the surface of this cell is not the H1 receptor that causes achoo, achoo, achoo. It's the H2 receptor. It's a different receptor. So Claritin or fexofenadine won't affect this. But specific drugs that are specific for the H2 receptor will inhibit this. Therefore, G cells stop making gastrin. Therefore, parietal cells stop making acid. You see how that works? A lot of these are over the counter. So there's famotidine. That goes by the trade name of Pepcid. There is rhinantidine. Ranitidine, sorry. That's the one that goes by the trade name of Zantac. Then there's cimetidine. That goes by the trade name of Tegamet. Then there's nizantidine, and I don't think, is nizantidine available in this country over the counter? Well, I'll just tell you, nizantidine. Sorry, no N. Nizatidine. That is called Axid. Notice that they end in tidine, 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 tidine. Sydney? That's correct. That's correct. So those are the names. What's it for? It's for heartburn. It's for peptic ulcer disease. It's for GERD. And it's also used for ulcer prophylaxis. Ulcer prophylaxis. Yes. Yes. Still called that. Does not work. My bag of tricks. Okay. Your responsibility, these are over the counter. Now, since they're over the counter, do they take them as directed? So you have to ask the right questions. Are you taking them as directed? How well do you tolerate them? Do you get symptom relief? So on and so forth. Let's talk about side effects. So reported side effects, even though these drugs usually are pretty well tolerated, reported side effects include headache, in some cases, dizziness, some cases, fatigue, some cases, somnolence, what's somnolence mean? It's more of you're sleepy. Somnolence means sleepiness. In older people, confusion has been reported. And with cimetidine, there are reports of gynecomastia. All of these may affect the absorption of other drugs, particularly drugs that require acid for their absorption. Cimetidine has a bundle full of drug-drug interactions. So if someone is on Tagamet regularly, kindly suggest that they pick something else because the price of these are pretty comparable. Cimetidine has quite a few drug-drug interactions. So that one is less preferred out of these. All right, now the big guns when it comes to this is going to be your proton pump inhibitors. These drugs are very effective. So these names, these include drugs that end with prazole. Prazole. So for example, omeprazole, lansoprazole, rabeprazole, omeprazole, pantoprazole, dexlansoprazole, blah, 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 blah. Your mother-in-law, prazole. So over here, prazole, it is a proton pump inhibitor. So on the cell, the surface of the parietal cell is a hydrogen ion, potassium ion pump. And it exchanges a hydrogen ion for a potassium ion. That's how it pumps the hydrogen ion into the stomach lumen in exchange for potassium. These drugs bind to that pump shut it down. They're very effective. Some of these are over the counter, some of these aren't. Omeprazole is over the counter. Lansoprazole is over the counter. Esomeprazole, Nexium is over the counter. Pantoprazole is not. Dexlansoprazole is not. And rabeprazole is not. What are they used for? So they're used for peptic ulcer disease. They're the drug of choice for peptic ulcer disease. They're used for GERD. And they're also used for a condition whereby you have a tumor of the G cells. So these G cell tumors make too much gastrin, so you make too much acid, so you tend to make ulcers. That is called, oh goodness, spell this right. Zollinger Ellison. Zollinger Ellison syndrome. Or ZES, as it's sometimes called. Okay. Let's do side effects first. So again, headache in some people. Also either constipation or diarrhea. In some people, there's abdominal pain. And in some people, there's nausea. On the average, these drugs are very well tolerated. These are what's been reported. Now, the beauty of these drugs, you do not have to adjust for renal function. You should administer these 30 minutes prior to a meal. That's a major education piece. Most people who take these don't take them properly. These have a long onset. Takes a day for these to usually work. There are some drug-drug interactions. That's something to keep in mind. The big E is going to be with cytochrome P450 2C19. Because most of these are inhibitors of 2C19. So if you have a drug that's inhibitor of 2C19, that's a problem. They are superior to the H2 receptor antagonists. So your other piece here is your responsibility is to tell patients, these are the best. Taking these over a period of time will promote healing. Most often see.
Yeah, like which ones do you think are like most?
The one that gets prescribed the most is pantoprazole. Protonics, I think that one's called. That one gets prescribed probably the most. Omeprazole is available on the counter. It's definitely the cheapest. Esomeprazole is a bit more potent. Well, no, it's more potent than omeprazole. Lansoprazole is about as potent as omeprazole. Dexlansoprazole is quite potent. So that's by prescription. So is rabeprazole. Okay. Now there's another compound that can promote healing of ulcers, and this stuff is called sucralfate. And this goes by the trade name of carafate. Yeah, carafate. This forms an adhesive, viscous adhesive that binds to the ulcer and promotes healing. So this is like, think of this as a bandage for the ulcer. All right, so that's the name. Use is for peptic ulcer disease. You could also use it for ulcer prophylaxis. Big thing here is aluminum toxicity. So you're going to want to keep an eye on aluminum toxicity.
No liking.
Side effects include constipation. Can be severe in some people. Some people experience nausea, dry mouth, pretty common. Metallic taste in the mouth, again, pretty common. The other is just aluminum toxicity. That's your big responsibility for this. So education is it will inhibit the absorption of other drugs. You can't use this to heal ulcers on its own. It needs to be combined with something else. So it's better than some of the other things, but not healing agent on its own. Can definitely help, but doesn't heal on its own. Very good at relieving symptoms. Because of the aluminum toxicity, if your patient has renal insufficiency, this stuff is going to accumulate. And it is not for acute symptoms. So somebody eats a taco time bomb and they get that awful stomach ache because they had one too many habaneros. Don't pop this stuff. It's too expensive. It's too big of a to-do. It's much easier to just pop a Tums or something like that. Okay. My wife made banana muffins for you guys, and they're really good. In fact, they're fresh out of the oven. So there's napkins here. Please feel free to, in fact, given the number of you here, some of you could easily have two. So I thought 24 of you would be here, but there's not very many of you here, but there's 24. So please don't be bashful. So, 5 minutes and then to have a muffin, please. They're quite good. I don't have to get it.
I'm grabbing stuff. Oh, thanks. Okay. Thanks. I'm like, oh, here's what
Is Renitidine, is FDA pulling Renitidine?
Sorry?
Or is FDA pulling Renit or Zantac? Are they pulling-
Ranitidine is being pulled.
Okay, that's fine.
Yeah,
I saw it on TV somewhere.
Yeah.
I read about it.
that's being pulled. That's in the process of getting pulled. Why cimetidine is not being pulled, I don't know, but ranitidine is being pulled. Yeah.
Was it causing cancer or something like that?
The evidence is not
Not very solid.
terribly solid, but there are increased incidents of people who use it long-term of certain types of rare stomach cancers. But it's not clear that the drug is causing it. I think the manufacturer is just saying, this thing's over the counter. A lot of people making it generically. We're not making that much money off it. So we're just gonna stop making it. So there's still stocks of it, but if they're stopped making it, so the stocks will deplete eventually.
Until it's gone.
Yeah. They'll switch to famotidine probably, which is very inexpensive. Anna, where do you get the pink masks?
I ordered them.
So instead of the usual blue, you can order pink. Oh, okay. I have one student who color coordinates with her mask. That's like some serious fashionista.
Yes.
They're pretty good, huh?
Warm it up with some butter on it. Your wife got this. Did you take it? And she start working over there. Yeah, shoot. Then I went pay $12.
Something we normally do at the end of the semester, we have a little I Survive Pharmacology shindig at my house. So during finals week, if you guys, I'll invite you all to come to my house and we'll have a little I Survive Farm shindig. And you get to meet my missus. We do it outside. We put blankets down, lawn chairs, and have fun. Okay, a minute or two, then we'll get started. Please have some more. I didn't have to tell Abby twice.
What'd you do?
Well, I could chew with your mouth open. We're not gonna say. I wish you guys on Zoom could see this. It's quite amusing. So here's what you guys are missing, just so you know.
Okay, Dr. B, let's see your best take Maggie.
Holding them out.
Ready? Oh, come on.
Did you guys get my copy of the epinephrine song?
Yes.
Yes.
Will you
See?
sing it again?
You remember it?
Will you please sing it again for us?
No.
I sing it great. Practice in my room. Okay, hang on. I'll sing it, guys. Ready?
If you guys work peds, kids are terrified of giving themselves shots. Little songs like that can make it a lot more fun. And because some kids just need EpiPens. But because it's a needle, they're terrified of it.
Whenever I spoke a toddler, I always sing on so Bailey called right now.
There you go.
We have an EpiPen, but she had a practice one in her thing. And she was practicing. We did a little scenario, right? She was thinking.
I ate a trio.
No, look at this video. What was it that you ate?
Okay. All right. Now, the synthesis of mucus by the stomach mucosa is actually induced by local prostaglandin synthesis. So if you wish to protect the stomach from acid, you can give compounds. Gang, can we please pipe down? Gang, can we please pipe down? Thank you. So this is a prostaglandin. And this will increase mucus synthesis in the stomach. And that helps protect it against stomach acid. This goes by the trade name Cytotec. Cytotec. Now, so that's the name. What's it used for? It's used usually if you're taking NSAIDs long-term and you want to prevent ulcers, then it's usually prevention of NSAID-induced ulcers. Really? The other thing it's used for is abortions. Okay. The medical abortions, it's a 2-drug combination. This is one of them. Okay. So your responsibility is this drug is abortifacient. Because it's abortifacient, you need to, if it's a young lady of childbearing age, then you need to do a pregnancy test. And then if she's sexually active, she needs to have appropriate contraception. That's if patient's a female. If she's postmenopausal, then it's not an issue, but if she's of reproductive age, then that's an issue. All right, so this one can form, some people get diarrhea on this drug. Others don't. There's a percentage that get it. Probably about 10% of people get abdominal cramping. Not a big deal in some people, but in some people it can be pretty substantial. Nausea gets reported relatively frequently. Flatulence. And then a headache. 3-4% of people get a headache. All right, so this requires QID dosing. So patients have to take this 4 times a day. So you have to make sure they take this. If they don't take this, they're not getting protection against NSAID-induced ulcers. So you have to stress that you have to take this. Even though you're taking it 4 times a day, you must take it. So that is misoprostol. Questions? Okay. Now we can get to agents that are prokinetic agents. Prokinetic, kinetic, what do you think that means? Movement. So kinetic energy, that's energy associated with movement. So prokinetic means they increase movement through the GI tract. So the first drug is metoclopramide. That is usually called in the hospital Reglan, because metoclopramide is a bit of a mouthful. This gets used for gastroesophageal reflux disease, but it's used as an adjuvant. An adjuvant treatment. Why? Because it increases gastric emptying. So you get increased gastric emptying. This drug works as a serotonin receptor agonist. That's one of the ways it works. Now, serotonin has multiple different receptors. So it's a receptor agonist for the HT4 receptors, but it's actually an antagonist for the HT3 receptors. Kind of a complicated mode of activity. So this is going to increase the cholinergic response of gastrointestinal smooth muscle. It will accelerate intestinal transit and gastric emptying. And of course, the big issue with this drug is, of course, you're going to get potentially diarrhea. But because this drug also is an inhibitor of the dopamine D2 receptor, you can get some of the effects of that. Now, if you inhibit the D2 receptor, remember, dopamine in the nigrostriatal pathway of the brain, that's important for voluntary movement. When that pathway, there's 4 different dopamine pathways in the brain, but when that pathway goes south, that's what causes Parkinson's disease, doesn't it? So you can get certain types of Parkinson type syndromes with this drug. That's one of the big issues with this drug is you can get, dizziness, drowsiness, and then the dyskinesias. Now, these go away once you get off the drug, so it's not permanent, but this can be very disturbing when a patient first gets on these. Big thing you have to be careful of with this is something called tardive dyskinesia. That we will talk about that when we get to our antipsychotics. That's a potential issue because this has a similar mode of action to antipsychotics. It can have some of the same issues. So with this, your responsibility is you're going to make sure you're going to watch balance. You're going to try to prevent falls. Falls are a big issue with Parkinson's patients, aren't they? And if they start to show strange movement issues, you want to contact the provider. So watch for movement abnormalities. This drug, you have to adjust for renal function. The reason it's used is that you get very good symptomatic improvement in patients with GERD. Yeah, that is regular. Okay. Let's talk about now, many of the drugs that you will administer during your careers can cause constipation. Because of this, this symptom is no laughing matter. I know we make jokes about it and stuff like that, but for people who have this, also certain infections can cause constipation as well. And some people get it when they fly, for example. There's a flight-induced constipation that's usually due to a change in time zones. Some people just get it when they travel in general. So that's travel-induced constipation. Other people, certain foods will plug them up. I will tell you just a brief story from my own life. I made a resolution I was going to drink more water because my doctor had chewed me out about not drinking enough water. So I took my big container and I walked over to this fountain down there and I filled it up every day. But the water in this building is not treated. It's full of iron. So you guess what happened to me? The more I drank, the more plugged up I got. Could not for the life of me figure out what was going on until we went on vacation and I was fine. And then it dawned on me, it's the water you're drinking. Oh, then I talked to the janitor. Do we have water treatment in this building? He said, no, we don't. And Spring Harbor water is full of iron. It's loaded with iron. So I was hyperdosing on iron. That's what was plugging me up. So if you get patients who are mysteriously plugged up and they're drinking lots and lots of water, you might want to consider your water source. Try drinking bottled water for a few weeks, see if that goes away. All right. Lots of things can cause constipation. Lack of exercise or activity can cause constipation. Insufficient fluid intake can cause constipation. Opioids biggie, can cause constipation. Some antihistamines can cause constipation. Certain types of foods, for example, alcoholic beverages, can cause constipation. Refined white flour products in some people cause constipation. Dairy products in some people cause constipation, and so can, if you eat too much of it, I'm sorry to say, chocolate. And also, in some people, cause constipation. Natalie, why are you looking at Paige?
She feels called out.
You're a chocoholic?
No, I.
Oh, you are. Okay. Well, that's okay. Now, typically with this, you're going to start with your lower active agents and then work up to things that are more powerful. There's lots of things you can use over the counter, some of which are actually relatively effective, especially if you use them in combination. So the first line of defense, shall we say, are the laxatives. These are colloidal compounds that absorb water. Because they absorb water, they'll tend to bulk up and hydrate what is in your colon. Therefore, they will distend the colon, they'll promote peristalsis, and they'll get things moving again, shall we say. So that's how they work. So these include things like there are products that are methyl cellulose. This is not digestible by bacteria in your stomach. It's not absorbable, but it absorbs a lot of water. Products here would be things like Citrusel. Then there's a very popular product, psyllium. That would be Metamucil. Then there's a polycarbaphyl product. This is the one you see in Meyer, Fibercon. All of these products work equally well. So they're used for constipation. You can get some bloating. Not terribly common. You can get some gas, otherwise known as flatus. You can also get a feeling of fullness in the abdomen. So the big responsibility really for the nurse is one, to just know that they're on it, but two, to make sure they don't overdo it. So just advise. For example, the containers will tell you to take this stuff with every meal. You don't need to. Really, you don't. Methylcellulose, what's that product? Benefiber. Benefiber, for example, once a day is fine. You don't need to take it 3 times a day. If you need more, than twice a day. But you don't need to take it 3 times a day. That's just using more product. That's going to cost you more. So no need to overdo it. So these are preferred first line. These are slow to act. They're not good for rapid relief. So if you need someone with rapid relief, these aren't going to do it. Also, with these, and this is big, in fact, I'm going to write this in another color so that you'll really see the importance of this. Tell your patient to increase their hydration. That's huge. If you don't, these may form a mass in the stomach or even in the intestines, and you may get obstruction. And that is a potential issue with these if you don't drink enough. So those are your laxatives. And if that doesn't work, then we go to another group of laxatives called the osmotic laxatives. The osmotic. So this would be another step up from the plain old laxatives. And this, and now Sydney's suggestion is come home to roost, milk of magnesia. So that, remember, is aluminum hydroxide. Sorry, magnesium hydroxide. Another one in here would be sorbitol. Sorbitol is an alcohol sugar. An alcohol sugar. Another one, very popularly used, polyethylene glycol. This is the stuff that is marketed as Miralax. You guys heard of Miralax? So these again, these draw water into the GI tract. They cause a very watery stool. Because of that, so that's the name. What are they used for? Constipation. Now, sorbitol, and then another product here called lactulose. These are both sugars that are not digestible. They're also not fermentable by most bacteria in the GI tract. These can be used for chronic constipation. Why do you use them for chronic constipation? Use them for chronic constipation because they're not going to cause electrolyte issues or pH issues. They're also not going to interfere with the absorption of other types of drugs or minerals or something like that. That's why these are good for chronic constipation. Now, the other issue with these is, again, as you ask questions, these should work within 1 to 3 hours. So you should have a rather prompt bowel movement. If they don't, something's wrong. So Make sure you ask the right questions. Let's take a look at side effects. These can cause gas. They, of course, can cause diarrhea. No big surprise there. You can get some cramping in the abdomen. And because you're losing a good deal of water, you can have some electrolyte disturbances. So, hydrate. Hydrate, hydrate, hydrate. Also, the other education piece, milk of magnesia should not be used for prolonged periods, especially in people with renal dysfunction. Instead, have them use sorbitol or lactulose. Those don't have to be adjusted for renal function. Yes.
So I know lactose is that causes a problem, or your body doesn't eat it anyway.
Lactulose sometimes is used as a filler in some tablets. If you buy lactate tablets, for example, those have a little bit of lactulose in them, usually, just as a filler. Because it's insoluble, it pellets well and helps pellet other stuff. So, okay. If that doesn't work, then you up your game. Now you're going to use laxatives that are stimulants. So these are going to directly stimulate the enteric nervous system. Remember, the enteric, the GI tract has its entire enteric nervous system. It has as many neurons as your brain does. And you're going to stimulate that. That's going to cause increased segmentation of the GI tract. So you get increased movement. And this would include things like there's an herb called senna, which acts as a stimulant laxative. This is the active component in X-Lax. There's also another preparation of it. Say it again. Senecot. So senna is one. Then there's bisacodyl. And bisacodyl is, there should be an S in there, sorry. Bisacodyl is like a detergent. So this is the stuff that's in Docalax or Correctol. Docalax, there are these incredibly tasteless commercials on TV for them. All right, so what are they used for? Constipation. These are very safe drugs. So what really your responsibility here is to assure the patient that they're safe. And if the patient needs them, to use them. They're used with opioids to prevent opioid-based constipation. They can be used long-term. They're quite safe. So that's the piece here I think you should really take home from all this. So side effects, you got some nausea in some cases. That tends to be more of a problem if you overuse it. cramping. In some people, abdominal cramping, again, not all that common. Water loss in some people can cause fainting. Of course, diarrhea. And then you can get some fluid and electrolyte loss. If you replace that properly with your diet, that's usually not a problem. So these work rapidly. They can be used on acute or chronic constipation. They're safe, they're very safe. They're especially safe for long-term use. And they can be used with opioids. And these play well with other drugs. You can combine these with the other laxatives. And that, in fact, is a strategy you can use for people whose constipation is intractable. You can layer drugs one on top of the other and get the relief you hope for. So these are good drugs. These are good drugs. Then you have a group of drugs that are called stool softeners. Stool softeners. And these tend to be detergents and things like that. The big drug here tends to be docosate, which this is the one that goes by Colace. Colace is available over the counter. Very good drug. Works very well. This breaks up material in the colon. It causes water essentially to flow into the material in the colon. And so it wets the stool, makes it easier to pass. This stuff is particularly good in people with hemorrhoids because bowel movements can be very painful in people with hemorrhoids. And these products, they're inexpensive and they're well tolerated. So recommend these, recommend these. Okay, so what are they used for? Constipation. Again, just asking the right questions. Are they using them? How often are they using them? So on and so forth. Side effects, same before, abdominal cramping, diarrhea, nausea. Mineral oil and glycerin can be used too, but they're not recommended. Mineral oil can cause severe nutritional deficiencies. Mineral oil can also has also been linked to aspirational pneumonia, so it's not recommended. The beauty of these is that they minimize straining. Because they minimize straining, they decrease symptoms and production of hemorrhoids. Docosate is used a lot if iron and calcium supplements are supplied. So docosate is used as a preventative in that case because iron supplements, of course, tend to really plug you up. So that's usually when you use docosate. Good product, very good product. Always takes longer than you think it does. Okay. Next are the Pomoras. These are being used less and less. These cause explosive diarrhea. These essentially are peripheral anti-mu receptor antagonists. That's where Pomora comes from. Peripheral mu receptor, mu opioid receptor antagonists. So what these do is these do not penetrate the blood-brain barrier. They just prevent opioid receptors from being bound by opioids in the bowel, basically. So they relieve constipation caused by opioids. They're very effective at that, but they tend to cause really, really bad diarrhea. Because of that, these are being used less and less. So the agents here, so there's imivapan, Interreg. There's methyl naltrexone. That goes by Relistor. There's two others that are on your list, I believe. So because these block peripheral opioid receptors, essentially the bowel becomes very active. So these are for opioid-induced constipation. They have their use in cancer patients who are on high levels of opioids to deal with the pain. And those high doses of opioids can just plug you up like nobody's business. So they have their use. Big responsibility here, short term. These are not meant for long-term use. You are not to exceed 15 doses. So do not exceed. Don't exceed 15 doses. Do not use in cases of liver impairment. Okay, and side effects, there's quite a few. We are out of time. I might have to end up podcasting this. We are severely behind. We're going to run out of time. So I need to soldier on. I might end up just putting all this on a podcast. So I will let you know essentially. And yeah, there was something else I was going to say. Oh, I need to do a straw poll. Okay, the bookstore is giving me some options because of the book that I'm going to use for micro next year. But I want people to have the Connect website, but the ISBN they gave me is just for the ebook and the website. So I'm taking a straw poll. Here's a straw poll. How many of you, by the show of hands, would want, if you were taking micro, say right now or next year, would want an ebook and not a hard copy? Let me see your hands.
I never use the hard copy.
You never use a hard copy. Sydney, you never use a hard copy?
No, I use Connect because it's cheaper to get Connect and the ebooks together than to buy the hard.
It is, but Last time I did, every time I do that, students on my evals trash me for using an ebook because they want a hard copy.
Can you offer both?
Then I have to give them 2 ISBNs, and then they have to decide how many books to buy because they don't know who's going to want what. So when I suggested that, Jane Asbury almost took me over to Lime Lake and dunked me in the water.
I would put your hard copy on there and then send an email out to all the students registered saying the hard copy is required, but recommended.
Or just be like.
Okay.
Say suck it up and get the hard copy.
Yeah.
Or they don't have.
Thing is, the hard copy is, by the time they mark it up, it's going to be $200.
Is it,
Can you tell them that we said that we never used it, so it doesn't matter? Like.
Okay, who out of you really likes a hard copy? Just,
I normally do, but I didn't.
For like a nursing book, yes. If I were gonna take nursing course like med search, I need a hard copy to write up. Micro, I could probably just like suck it up and use the ebook. Because essentially I wouldn't mark it up as much as I would like a med search.
see, with all the CME stuff nurses are doing now, it's all online. All of it.
But like with our med search book, we're gonna use it for med search 1, 2, and 3.
Yeah.
It makes sense to buy a hard copy.
Well, yeah, it's just with micro. So it sounds like I should just go with the ebook.
Yes, I would just do that.
And if they trash your emails, tell them they're in the butt and they need to get out of here. Like ours is a hard copy
Yeah, like you just have to.
other ways.
Most
Not this
people-
one because it's a brand new edition.
Well,
Most people won't buy it from the bookstore because the bookstore like
no, they're most of the
so
time.
expensive.
We never buy from the bookstore. We learned that the hard way.
In the expensive way.
Okay. All right, gang, we're done. So have a good evening and I will see you guys hopefully on Monday.